transplantation. Today we are going to talk about role of Tecartus in mantle cell lymphoma and acute lymphoblastic leukemia. We have a distinguished speaker, Dr. Muhammad Bakkar, who is a consultant of adult hematology and hematopoietic stem cell transplant division of adult hematology and stem cell transplant department of oncology at King Abdulaziz Medical City in Riyadh. National Guard Hospital. Dr. Muhammad Bakar has special interest in the advanced therapy for acute lymphoblastic leukemia for adult patients. And he's going to talk about CAR-T treatment for mantle cell lymphoma and acute lymphoblastic leukemia. Before we start, I would like to thank the sponsor of these activities, Gilead Kite, for sponsoring this webinar and previous webinars related to CAR-T therapy. And I would like to thank Saudi Society of Blood and Marrow Transplantation for organizing this event and previous event and inviting me and Dr. Bakkar. So, Dr. Bakkar, kindly, if you can start your presentation.
Thank you, Dr. Zahrani, for this nice introduction. And I would like to thank SSBMT and organizing committee for giving me the opportunity to present here. And I would like to thank also Kite for sponsoring this event. So I'll be talking about the role of Tecartus in mantle cell lymphoma and acute lymphoblastic leukemia. We'll have a few introduction about B-cell lymphoma and CAR-T. Then we'll talk about CAR-T cell in mantle cell lymphoma, followed by CAR-T cell in acute lymphoblastic lymphoma, the acute lymphoblastic leukemia. So B-cell development are generated and developed in bone marrow, and mature B-cell travel to the peripheral blood. CD19 is unique B-cell marker and present throughout the most of the B-cell maturation process in the pattern of and expression maintained across the different B-cell malignancies. CD19 present in most B-cell leukemias, lymphoma, but not in any normal tissue other than B-cell lineage. So how would you improve the tumor antigen recognition and cytotoxic potential of T cells? We have physical proximity of T cells that we do it by specific antibodies, simultaneous binding of T cell and cancer cell targeting to help T cell recognize the cancer cells. That's what we do in bispecific antibodies. Then there is a cancer vaccine that will boost recognition of tumor antigen, making tumor more accessible and target cytotoxic T cells. Other way to improve the system, transfer antigen of specific T cells, which we call it CAR T cells, and finally disable the inhibitory signal of activated T cells by checkpoint inhibitors. So the CAR T cell therapy are genetically modified autologous T cell immunotherapy that bind antigen expressing cells, either CD19 or BCMA, including normal and malignant cells. A CAR T cell construct consists of extracellular antigen binding domain and hygiene region, transmembrane domain, and intracellular signaling domain. So when you give CAR T cell to the patient, it go to the peripheral blood, then it go to tumor cells. It attach to the tumor cells, then it cause death of cancer cells and antigen release. That will lead to new antigens that go to antigen presenting cell, take it to the endogenous T cells and kill the tumor. So there's multiple approved FDA approved CAR T cell therapy. In diffuse large B-cell lymphoma and aggressive B-cell lymphoma, there's axi-cell and Liso-cell and Tesa-cell. It's used as upfront treatment as second line and third line in case of relapse refractory aggressive lymphoma. For follicular lymphoma, there is axi-cell that been approved for relapse refractory second line follicular lymphoma. Also, Liso-cell is approved for second relapse and refractory second second line for peripheral lymphoma, also Tisa-cel that's approved beyond second line. For mantle cell lymphoma, there is Broxacel. It's only approved drug for approved CAR T-cell relapse refractory. Also Laser-cel approved for relapse refractory cases. For B-cell acute lymphoblastic leukemia, we have three CAR T-cell, which is Broxacel and Tisa-cel and Obe-cells. It's all used for relapse refractory cases. Tisa-cells used for, which is Kymriah, used for age less than 25 and mainly pediatric as a second line. So we'll focus in CAR T-cell in mantle cell lymphoma. So mantle cell lymphoma, it's compromised around 5 to 7% of all B-cell lymphoma, and to have standard risk. If you see this nice picture, so how mantle cell lymphoma progressed to either classical mantle cell lymphoma or leukemic non-nodal mantle cell lymphoma. So this is very detailed slide, show you how to manage high-risk mantle cell lymphoma. We will focus only on relapse cases that and role of CAR T-cell in those cases. This is a recommended upfront treatment for mantle cell lymphoma. As you know, it's either R-CHOP or BR that was shown in STILL and BRIGHT study. Also in European mantle cell lymphoma of young, they use high-dose chemotherapy followed by autologous transplant. And in China trial, they use bendamustine, rituximab, plus minus ibrutinib. And finally, in triangle trials, it showed that patient who had who use ibrutinib, he might need you can delay the autologous transplant. So upfront treatment, there is many choices, especially for young. And if you would like to incorporate autologous transplant, there's two studies that use European Mantle Cell Lymphoma Network. They give R-CHOP followed by autologous transplant, giving BFS and overall survival around 7 years. And triangle, they defer the transplant because of if you use ibrutinib as a maintenance. So these slides focus in relapse advanced mantle cell lymphoma. It showed asymptomatic indolent, you don't need to treat, but if they have symptomatic and progressive disease, if they have ibrutinib or BTK naive, you could use either CAR T-cell or if they have ibrutinib naive, you can use BTK or ibrutinib venetoclax or CAR T. Other patient has used BTK in the past, you could use CAR T-cell and venetoclax plus or bertobrutinib. And you could consider finally allogeneic stem cell transplant if CAR T-cell failed. So for targeted therapy in mantle cell lymphoma, this is a slide showed the summary for the CAR T-cell approved drugs, ibrutinib, zanubrutinib, acalabrutinib in relapse refractory setting, and also lenalidomide and rituximab, with anti-CD20s approved as a relapse setting. For immunotherapy, Broxacel is approved, and there is off-label use of glofitamab and loncastuximab. So this study for Broxacel in relapse refractory mantle cell lymphoma was published in New England Journal of Medicine, which is called ZUMA-2. So Broxacel is autologous CAR T-cell therapy produced and manufacturing process that removes circulating CD19 expressing malignant cells. Removal of these cells may limit the potential activation of exhaustion anti-CD19 CAR T-cell during the ex vivo manufacturing process. Following anti-CD19 CAR T-cell engagement with CD19 expressing CAR T-cells, the CD28 and CD3 zeta co-stimulatory domain activate downstream signaling cascade that lead to T-cell activation and proliferation with acquisition of effector function and secretion of inflammatory cytokine and chemocytokines. So ZUMA-2, they have enrolled cases of relapse refractory mantle cell lymphoma. The optional bridging therapy was dexamethasone, ibrutinib, also acalabrutinib, Conditioning chemotherapy, they give the lymphodepletion was fludarabine 30 milligram and cyclophosphamide 500 milligram per square meter in day minus 5 to day minus 3. The primary endpoint was overall response rate. A secondary endpoint was disease of duration of response, progression-free survival, overall survival, and adverse event. They give CAR T cell after lymphodepletion around 2 multiplied by 10/6 per kg, a single IVD infusion in day 0. So the patient eligibility, they include all patients with relapsed refractory mantle cell lymphoma. It's defined by disease progression after last regimen or failure of achieving CR or PR in the last regimen, either 1 up to 5 line prior therapy. That include anthracycline, bendamustine chemotherapy, anti-CD20 and monoclonal antibodies, and ibrutinib or acalabrutinib. They have more than one measurable lesion. Patient with they have cyclin D overexpression or presence of translocation 11-14, age more than 18, ECOG performance status from 0 to 1, adequate renal, hepatic, pulmonary, and cardiac function, and the absolute lymphocyte, they have to at least more than 1 per cubic millimeter, so more than 100. So the cake exclusion: patient prior allogeneic stem cell transplant, prior CD19 targeted therapy, prior CAR T cell, patient with history of current CNS involvement by mantle cell lymphoma, history of MI, cardiac abnormalities in the last 12 months. So they enrolled around 74 patients, leukophorist. Then the conditioning lymphodepletion was given for only 69 patients because 5 patients was dropped because of manufacturing failure and to death, and only 68 patients received Bruxelles therapy in mantle cell lymphoma. Bruxelles was successfully manufactured in 96% of the patient and administered to 68 patients. Median time from leukapheresis to delivery of Bruxelles is around 16 days. So the baseline characteristic, median age was 65. It's male to female, male 87, 84% male, stage 4 disease on 85% of the patient, ECOG, bulky disease in more than 35% of the patient or 10% of the patient. Cas67 was more than 50 and 69% of the patient, 17% they have TP53 mutation, and bone marrow involvement in 54% of the patient, and mantle cell morphology was classic in 60%, pleomorphic in 6%, and blastoid in 25%. Median number of therapies around 1 to 5, and they have most of them they receive anthracycline 99 and bendamustine 99% of the patient. All patients receive BTK inhibitors. 43 patients has relapsed refractory disease, and 100 all the patient has received BTK in the past. So the bridging therapy was administered with those with high disease burden at BI decision, not intended to be curative, but to maintain stable disease prior to Bruxelles infusion. No chemotherapy was allowed. 23 patients out of 25 had post-bridging PET scan, and majority of them increased in SBD millimeter from screening. The bridging therapy was either either BTKI or dexamethasone steroid, both BTKI the steroid. So the summary of efficacy, there is 3 year, there is primary analysis, 1 year follow-up and 3 years follow-up. So we'll focus on 3-year follow-up. There is 68 patients enrolled. Overall response was 91%, with 68% achieved complete remission, 37% still ongoing response. Median overall survival was 49%, and median PFS was 28.5 months. Again, the This is a primary analysis efficacy by independent investigators. So the complete remission was around 70% by investigator assessed efficacy, and disease progression only 3%. So the best response in this study, it almost complete response in 67%, almost 70% they have a complete response, and the duration of response up to 12 months up to 60, almost 60%. The progression-free survival was 61%, and overall survival at 12 months is 83%. So this is an example for one of the patients who was enrolled in this in the Zuma 2, 50-year-old male patient with three prior previous therapy for mantle cell lymphoma, presented with multi-compartment mantle cell lymphoma. If you could see the baseline PET scan was involved all the bodies, stage 4 disease. After 1 month, almost cleared all the lesion has cleared, and at 12 months, all maintained his complete remission. So with the Broxacil, he achieved complete remission at 3 months and remained remission at 18 months later. So the 3 years analysis of this study, again, overall response reached up to 68, overall response up to 91%, 68% they maintain complete remission, around 46 patients. The other patient, 4%, they have stable disease, and only 3 patients has progressed. The duration of response, median duration of response has not been reached after median follow-up of 12 months. 3 years analysis, median duration of response was 28 months among 62 patients with either CR or PR. The median PFS was not reached after 12 months, but at 3 years analysis, the median PFS was around median 24 PFS rate was 52%, almost 53%. Overall survival, 3 years overall survival is for 46.6%. So the cytokine release and neurotoxicity over the time, the incidence, the median follow-up 12 months, all grade incidence is 91% of the patient, they have all grade CRS, 15% they have grade 3 and more CRS incident, and for neurotoxicity, 63% they have all grade ICANS, only 31% they have grade 3 to grade 4 neurotoxicity. The fever, it's almost this is the side effect. If you see the major side effect, grade 3 to 4 is almost, you could see the fever, 13, most of the patients, they have fever, grade 1 to 2, hypotension only in 19% of the patient with grade 3, hypoxia in 12% of grade 3, and there is only 2 cases grade 5, 2 deaths. The grade 5 adverse effect, it was organizing pneumonia and patient with Staphylococcus bacteremia. The CRS symptoms, as we said, 68 patients, the any grade CRS 91%, 12% grade 3, 3% grade 4, mainly fever in 91% of the patient, hypotension in 51% of the patient, and hypoxemia in 34% of the patient. Around 21% of the patient, they have severe they have grade 3 hypotension and hypoxemia. CRS onset management, it was 59%, almost 60% managed by tocilizumab, 22% managed by steroid, and 16 managed by inotropes. Median time to onset from 2 to 13 days, grade 3 from 1 to 9 days, median time to event resolution around 11 days. For neurotoxicity incidence, again, grade 3, 22%, grade 4, 9%, the main grade 3 male encephalopathy 9 and 10%, and confusion set in 12%. The neurology onset and management, it was managed by tocilizumab and steroid, 26% tocilizumab and 38% they give steroid. There's no grade 5 neurological event. One patient had grade 4 cerebral edema. The patient fully recovered with aggressive multi-modality therapy, including ventriculostomy. So this is the overall duration of response and overall survival for Broxacil, which shows a significant improvement in patients with relapsed refractory mantle cell lymphoma, make it one of the best choices as second line and third line salvage for patients with mantle cell lymphoma. This is real-world analysis it was published in Blood 2 years ago. It showed almost same data. They have around 52 patients. Those patients achieve BFS around 68% and overall survival around 85%. So Broxacil induced durable remission in majority of patients with relapsed refractory mantle cell lymphoma. Now we'll talk about CAR T cell in acute lymphoblastic leukemia. It's mainly B cells. So as we know that acute lymphoblastic leukemia outcome has improved significantly in the last 20 years. The 5 years relative survival, 72%. Estimated new cases in USA around 6,000 a year. Estimated death in 2024 was around 1,300. And now in Saudi Arabia, acute lymphoblastic leukemia around 800. Leukemia in general, we have around 800 per year or 850 per year, 5.9% of all leukemias. But if you B-cell ALL around 57 cases and 33 acute leukemia non-specified. So we have around 60 to 70 cases per year adult acute lymphoblastic leukemia. So the overall survival, this graph show you how the improvement of acute lymphoblastic treatment over last 40 years, from deadly disease with survival less than 10% in pediatric to up to 98% survival. So even in adult patient, the survival was around 34% or 35% in the past for 5 years. Now almost 77% using hyper-CVAD with immunotherapy. Again, in less than 30, less than 60, the overall survival improved from 30% to 66%. Even elderly patients, they were in the past, all of them, they die within one year. Now with the treatment, improving the treatment choices, 60% of them, they have 5 years survival. This is elderly patient. ECOG trial that showed MRD negative patient who received Plina, they showed significant overall survival. Patient less than 55, they have 94% PFS, but that's make it standard of care for upfront treatment in patients with acute lymphoblastic leukemia. For Philadelphia positive, it was the survival before 2000 was around 13%. All patients, they have to do transplant. Now survival improved with Plina protocol and Plina protocol up to more than 90%. We're targeting MRD is a goal in acute lymphoblastic leukemia. If you achieve MRD negative, they have good disease-free survival. So that's a summary for acute lymphoblastic leukemia. We treat upfront therapy with modified IL protocol using Plina up to age 55. Some center they use hyper-CVAD, Plina, inotuzumab. For refractory disease, inotuzumab, blinatumomab, if the blast is than 50%, bone marrow transplant if they achieve complete remission, and CAR T cell therapy. For elderly patient, there's Eno then Plina, as per Alliance study. Mini hyper-CVD with Eno Plina, named Anderson. Also Eno plus chemotherapy in some centers. The Philadelphia positive, now using TKI Plina without chemotherapies could be standard of care in some centers. TKI chemotherapy plus minus transplant. So this is evolving of treatment of landscape of acute lymphoblastic leukemia. So from 2010 until now, there's a lot of modality of treatment include Blina in 2017, and ituzumab, and CAR T cell in 2013. Now those dense hyper CVD, also hyper CVD with Blina, So there is significant improvement in acute lymphoblastic leukemia care overall. So what is the role of CAR T cell in acute lymphoblastic leukemia? So we have three CAR T cell now approved by FDA. The first one, based on Uliana trial, Tesa cells, which is Kymriah, to use for relapsed refractory B acute lymphoblastic leukemia age less than 25, and used for second relapse or later. And unfortunately, we can't use it in adult more than 25. We have Zuma 3 trial, which we'll talk in details later, for Brexucells in relapsed refractory B-cell acute lymphoblastic leukemia. We have Felix trial. They use obe-cel, which is used in relapsed refractory B-cell acute lymphoblastic leukemia. So we have three available therapy. I think in Saudi Arabia, we have Tecartus and Brexucel. So this Zuma 3. Again, this is the roadmap. The patient include relapsed refractory B-cell ALL, defined as number 1, primary refractory disease, patient with first relapse in the first remission less than 12 months, patient relapsed refractory after second line of systemic therapy, patient relapsed refractory after allogeneic stem cell transplant more than 100 days after stem cells. They have to have more than 5% plus in the bone marrow and age more than 18, ECOG 0 to 1, Philadelphia positive. If they are intolerant or relapsed refractory to disease, they can be included. Patient previously treated with blinatumomab and have CD19 tumor expression in the bone marrow are allowed. So the bridging therapy and safe prophylaxis, then conditioning of lymphodepletion therapy was fludarabine. Again, cyclophosphamide with fludarabine. They use cyclophosphamide 900 milligram per square meter, not 500, with 25 milligram fludarabine. Then they infuse Brexucel, the dosing 1/10 multiplied by 10 power 6 of CAR T cell per kg in day 0. So the primary endpoint was complete remission, and the secondary endpoint was duration of remission, overall survival, MRD negativity, and allogeneic stem cell transplant, relapse-free survival, safety. So the baseline characteristic, so they have around 55 patients enrolled in Zoma. Male ECOG performance 1. If they have patient with Philadelphia positive, 27%. CNS disease at baseline was in all patients almost 100%. Number of prior therapies from 2 to 3. Some patients receive up to 5 prior therapy. At 45% they receive Blina, 22% they receive ituzumab, and 42% they have previous allogeneic stem cell transplant. So the blast range from 5 to 100%. So the primary analysis of the phase 2, they enrolled 71 patients enrolled. They underwent leukapheresis. 14 patients not treated because of adverse event. 3 patients was not eligible. 1 partial consent withdrawal. So there's only 57 received conditioning chemotherapy, and 55 received Brexucel, because 2 patients after conditioning, the one have adverse effect, 1 not eligible. So the 55 patients received, this is 2-year follow-up analysis. The 55 received Brexucel, 39 patients achieved complete remission and complete remission or CRI. 16 patients did not achieve. 16 patients did not achieve complete remission. So 6 patients have ongoing remission without subsequent allogeneic stem cell transplant. 10 patients received subsequent allogeneic stem cell transplant, 6 patients ongoing remission, 1 relapsed, 3 died, 6 patients started new anti-cancer therapy, and 14 patients relapsed, and 3 patients died. The subsequent stem cell transplant rate after Broxacil around was 20%. So the second year follow-up showed that 70% of the patient they achieve either complete remission or complete remission with incomplete hematological recovery. Ongoing response for around 30%. The median overall survival is 25 months. The median duration of response is 14 months. So the best overall response, the 70, as we say, 70%, they achieve complete remission. And 60 of them achieved CR and 15% achieved CRI. Patient no response 16%. And 7.3 they have disease progression. So this is subgroup analysis for all patients. If you see all responding patient, you can see the age make different. Patient with the CNS status as screening blast in the bone doesn't change the outcome. But if the patient has 75% and more blast, they have better outcome. The 2 years response outcome by age and bone marrow. Consistent with primary analysis, CR complete remission is very independent. There's around 71% complete remission, and 56 of them they have CR complete remission without with full complete remission. 71% their overall response. Efficacy outcome in each subgroup, age and bone marrow blast were largely consistent of all cell treated population. If you could see that the patient with there is around the blast, high blast again associated with could be associated with when blast more than 75%, 36% of them they didn't respond, but around 42% despite of high blast they achieve remission. So the safety outcome, of course, most of CAR T cells they have the common side effect, which is fever, CRS, and ICANS. If you see the grade 3, we'll focus on grade 3, hypotension in around 31%, and anemia, and the patient with hypokalemia only 5%, tremor only only in 1 patient. All treated patients had at least 1 adverse event, and serious adverse event occurred on 75% of the patient. 11% patient died due to grade 5 adverse event, other than acute lymphoblastic leukemia, 2 related to brain herniation at day 8 and septic shock at day 18, and 4 are related to Broxacil treatment. So for primary analysis of cytokine release syndrome, because there's grade 3 and grade 4 CRS around 24%. There's no grade 5 CRS, but for neurological event, there's 25%. They have grade 3 ICANS, and 1 patient had grade 5 brain herniation related to treatment. Tocilizumab was given to 80% of the patient. Steroid was given to 75% of the patient, and vasopressor given to 40% of the patient. The most common side effect it's for a neurological event was tremor 27% and confusion 25%. Around 67% of the patient they have hypotension, so grade 3 to 4. After this study, ZOMA-3 led to approval of FDA for Broxacil in relapsed refractory acute lymphoblastic leukemia. So we have 4-year update and 5 years update. The median follow-up around 4 years. The overall survival again 25 months in all patients. 47 months in those who achieve CR. Non-relapse mortality was 25%, and mainly in patients who go to stem cell transplant. Then the 5 years update was presented, I think, in ASCO 1 year ago. It said 5 years overall survival was 40%. Median overall survival was 25 months. Median overall survival 53 months among responder. So in patient age more than 26 years, they're around 63 patient, 5-year overall survival 42%. That's interesting in the 5-year follow-up that median and 5-year overall survival were low in responder who subsequently proceed to allogeneic stem cell transplant versus those who did not do stem cell transplant. So the median, the overall survival dropped from 52% to 42% if the patient do stem cell transplant. This is a 5-year follow-up. And the safety profile was consistent with the previous report for there's one the death and one cancer, one pulmonary failure. And 5-year follow-up results demonstrate continue to provide durable survival benefit for all patients with relapsed refractory BCL, regardless of the age, the prior therapy, and subsequent allogeneic stem cell transplant. So either patient receives stem cell transplant or not, they are candidates for CAR T cell. So this is the long-term follow-up of overall survival for all responder by subsequent stem cell transplant. Median overall survival for patient who received transplant was 50 months, and without transplant 60 months. There's little bit drop in patient who did transplant. It could be related to transplant mortalities. Overall survival for ages than 26, as we mentioned, patient who did transplant, they do less. They survive less than patient who didn't do transplant. That's small. Actually, there's a small number of disease, around 58 patients, 47 patients. So we couldn't decide if really stem cell transplant patient who achieve complete remission, they're still candidate for stem cell transplant, and because of proxy cell, they could lose their effect with the time. So the summary for 5-year follow-up for ZOMA-3, patient continue to experience survival benefit with 40% 5-year overall survival. The benefit is regardless of the age, prior therapy, subsequent allogeneic stem cell transplant. As we said, it's small group, and we cannot judge its ambulance patient characteristic, limit interpretation for post-hoc analysis. There's no new safety signal were observed after 5 years of follow-up for proxy cell. So there's a question: if patient has CNS leukemia, will he be a candidate for CAR T cell or not? So this is proxy cell outcome for patient who relapse refractory acute lymphoblastic leukemia with CNS involvement. It was published in Blood Advance. They have high CNS response in patient with who receive proxy cell, and there's no difference in ICANS or CRS. Again, if patient has CNS leukemia. So this study, it was a retrospective study. They collect all the patients who receive proxy cell. There was around 189 patients infused with proxy cell. 31 of them, they have CNS disease. 15 they have CNS 2, 16 with CNS 3, and they receive proxy cell. Then they follow their outcome. So the complete remission MRD negativity is almost similar to patient who didn't have CNS disease. The outcome here showed that either you have CNS disease or no CNS disease, the BFS will be around 50, and overall survival around 50 or 70 around 65%. So there's no significant difference if the patient has CNS disease or not. And the second question: will they have more ICANS if they have CNS leukemia? No. Patient who has refractory relapsed CNS leukemia, they can be a candidate for proxy cell, and the CRS for a patient, and ICANS almost similar in both group. ICANS 35% in patient with CNS disease, 30% patient without CNS disease, all grade 64%, 54%. There's no significant B value here is not significant. So either patient has CNS leukemia or not, the outcome is almost same. and toxicity has no difference. So this is a summary for CAR T cell treatment for acute lymphoblastic leukemia. If you see the table, it will see the T cells, which is CD19, been 41 pp. Eliana study, this involved only 75 patients. CR was 81%, 12-month overall survival 76%, and ICANS was 13%. Severe CRS was 46% in patient with T cell. The immunotoxicity mainly neutropenia and thrombocytopenia, B-cell aplasia, hypogammaglobulinemia 3%, 83% they have B-cell aplasia for up to 6 months. Secondary malignancy reported in 3 cases of T cell. For Broxacell, there is ZUMA-3, they involve 55 patients. As we mentioned, complete remission 71% for Broxacell, and overall survival 81%. The ICANS and CRS is less. It's around 24% grade 3 to 4 CRS and 26% ICANS. The immunotoxicity, they have neutropenia, thrombocytopenia, up to 50%. B-cell aplasia, 40% of the patient, they develop B-cell aplasia. OP cells, which in the FLEX study, CD19 fast off is 41 bb. They include around 127 patients, and CR 74%, for survival 64%, less than Proxacell. And again, the toxicity here, CRS 2% is less toxic than other CAR T cell. CRS 2% only, and ICANS 7%. So what is the future of CAR T cell therapy? So if you have patient with relapsed acute lymphoblastic leukemia, there's CD19 expression. If they have negative, you have to look if there is negative CD19, you have to look for CD22 CAR T cell or bispecific CAR T. This is the future. Then if they have positive, you have CD19 CAR T cell. If the patient has poor T cell number or functions, you can consider allogeneic CAR T cell, which is ongoing study on it. And if they have CD19 positive relapse, either you use another CAR T cell or another product, or you consider allogeneic stem cell transplant. If CD19 negative relapse, you have to consider the CD22 CAR T cell. This is ongoing study on it, and allo stem cell transplant CAR T. It's high-risk disease or MRD relapse. So bridging option, we have inotuzumab, radiotherapy, TKIs, chemotherapy, cautious using FLAG-IDA or CD19 targeted therapy. Future exploratory strategies, concurrent TKI using for Philadelphia positive ALL, CAR T cell as a consolidation, complete remission, and CD19 feeding T cells. So in summary, Proxacell is for induced durable remission and in majority of patients with relapsed refractory mantle cell lymphoma. Again, Proxacell has survival benefit in relapsed and refractory ALL regardless of age, prior therapy, subsequent stem cell transplant. Proxacell showed high CNS response rate with a CNS PLP acute lymphoblastic leukemia, with no difference was detected in rate of ICANS or CRS. And this is the end. Thank you.
Thank you, Dr. Mohammed Bakar. Very nice, comprehensive presentation about the CAR T treatment for adult patients with mantle cell lymphoma and acute lymphoblastic leukemia. Again, we will have the Q&A session now, and please, anyone has any question, you can post it in the Q&A box or in the chat box. And maybe I will start, Dr. Muhammad. Again, very nice presentation. I attended in the ASH, the last ASH 2 weeks ago. There was an oral presentation from the USA Consortium ROCA study, real-world evidence using Proxacell in adult patient with ALL. They compared 3 groups. One group who did not undergo, just received CAR T, Another group received CAR T, then underwent allogenic transplant, and the third group who did the transplant and subsequently received CAR T. And they have shown that opposite to what you mentioned in the 5-year long-term follow-up, you mentioned there is no benefit from transplant, but they have shown different result. Those patients who underwent transplant, either pre-CAR T or post-CAR T, they have survival advantage compared to those patients who receive Tecartus without transplantation. And this is real world evidence, and they have, I think, a good number of patients, more than 150 patients. If you have any comment.
Yeah, I agree with you. As I mentioned, that the study was only few patients, so only for 50 patients, around 10 or 14 patients, they did transplant. So the number of the patient, they couldn't judge that really effective. Even their outcome, when they report the 4-year outcome, showed the stem cell transplant was better, but when they report 5 years outcome, it showed no different. But again, that's only in this study. But I believe that most of the, as you said in ASH last ASH 2 weeks ago, they said that patient who did stem cell transplant, they have a lot of they get benefit, and their overall survival, they could be better with the stem cell transplant. So for most of the patients and most of the practice right now, if any patient with relapse ALL, if they didn't achieve CR, you could give them CAR T cell to achieve remission followed by stem cell transplant. This is almost standard of care. And patient who did not, you can, and if for obesal, some centers for high risk patient, they give them CAR T cell as a consolidation, even if they didn't have post allo transplant. They give them as a consolidation, even if this MRD negative. Some patients with high risk for relapse. So in general, stem cell transplant still standard of care for patients with relapse refractory acute lymphoblastic leukemia, either you use Tecartus or not.
Is there a difference in the recommendation of transplant comparing the three products, Tecartus, Tecartus, and Ovisil?
No,
Like, for example, for Tecartus in general, there is no recommendation for transplant post Tecartus. Is it different compared with other product?
Yeah, for Tecartus, it's not recommended to transplant them. For Broxacil, because the duration of response is many patients cannot maintain, so it's better to transplant them if they are MRD if they are MRD negative. And Opacil cell, I didn't have all the data. I just reviewed the Flex study that most of them they receive CAR T cell without transplant, but I didn't have all the data for this.
So based on this, the products that we have in Saudi Arabia now, Tecartus and Broxacil. So if we do CAR T with Broxacil, we should follow that by allogeneic transplant.
Yeah, I agree with you. Yes.
Okay, great. Thank you. We have a question here. Do we need to have a CD19 positive relapse before CAR T? Is
Uh,
it, do you check for CD19
yeah,
at the time of the relapse?
a patient with the ALL, they have to have CD19 positive upon relapse. If they're CD19 negative, they have no role for CAR T cell. So they have to have CD19 positive relapse.
So what will be the options for if you check for CD19 and it's negative, what do you do for these patients?
So yeah, that approach will be inotuzumab and followed by stem cell transplant.
Okay, great. The other main theme that I find from the presentation is neurotoxicity is significant post Broxacil. It reached like 9% grade 4 in mantle cell lymphoma and 25% in ALL grade 3 and 4. I think this is significant. There was like mortality in ALL
Yeah,
like grade 5. So Does this have any specific recommendations for the management and prophylaxis for these patients?
For management, of course, of early management, the steroid steroid and steroid treatment is good, especially pulse steroid if they have grade 3 to 4. And for prophylaxis, you could consider the steroid as a prophylaxis or anakinra.
Okay, good. The other question here is how should Tecartus be sequenced with other therapies such as BTK inhibitors, blinatumomab, inotuzumab? If you have all these options now, where do you consider the CAR T therapy in other patient with ALL?
If you have actually in mantle cell lymphoma, the Broxacil showed durable response in second and third line. So if you have access to CAR T cell, you can consider the second or third line, because there was a slide about the first slide about the patient who progressed, they have BOD 24, they who progressed within the first 2 years, they have very poor prognosis. Those kind of patients, they would most likely even they relapse after BTK treatment. So those kind of patients with high maybe score mantle cell lymphoma and high BO24, this is you should be considered. The who relapse within 2 years, they have to consider for CAR T cell early.
Okay. Last question, Dr. Bakar. Looking forward, do you see Tecartus moving earlier in therapy lines? And could it be eventually replace transplant in selected patients?
Actually, because of duration of response and viability of CAR T cell, it's lost with the time. So I don't think that Tecartus Broxacil will replace this allogeneic stem cell transplant at this time. And still, patient who's candidate for stem cell transplant, he should go for transplant. Obacil is the Obacil is ongoing, and there's good data on it, but we didn't have the all result. So we believe that with the future, with new generation of CAR T cell, they could replace the transplant, and in the future we'll have allogeneic CAR T cell that can also replace stem cell transplant. Right now, still stem cell transplant from matched donor is the best therapy.
Okay, great. Thank you very much, Dr. Muhammad Bakar. Very nice presentation and discussion. Again, I would like to thank all attendees. And also, I'd like to thank Saudi Society of Blood and Marrow Transplantation for organizing this event or webinar. And at the end, I'd like to thank Gilead Kite for sponsoring this event. At the end, thank you all and have a good night. مع السلامة.
Thank you.
مع السلامة.